Sure. My name is Roger A. Levy, Levy. I'm a rheumatologist. I went to medical school in Brazil and then trained rheumatology in New York at the Hospital for Special Surgery, Cornell. My main interest has been with lupus all my life, and I'm talking about the 1980s till today. I got out of medical school in 86. And then I went back to Brazil. I was a professor at the State University in Rio de Janeiro until 2017, when I was invited to join GSK as a global medical expert. So I'm based in Philadelphia, but I work with global, which means the rest of the world except the US, but I also support the US when they need me. And before I joined GSK, I did the clinical trial. First, the first trial, Bliss 52, then other trials with belimumab and other products for lupus and other diseases as well. But my main area has always been lupus and allied conditions. So I started to see patients having results that we never had before. And I was a speaker, advisor for GSK until they asked me to join the company. So it's been 5 years now. Yeah, so there is a variation depending on where we go geographically and the racial background. So it's mostly women. So it's 9 females to 1 male. And it, in general, starts around the 20 to 30 years. So we can have teenagers too, starting with the disease, but mostly around their 20s, 30s. So young woman, mostly. And it's a chronic disease, meaning lifelong treatment, lifelong avoidance of the complications that we know. And we now today focus on the treatment, thinking not only the short-term result, which the patients want to see right away, but also, since we're talking about young people that will have a chronic disease, we have to think of the long-term complications that we call the damage, and those damages are irreversible. And we know that the more damage there is a higher risk of further damage accrual and early mortality. So if we talk about the age range between 16 to 24, this woman with lupus is 20 times more likely to die than another woman with no lupus at that same age range. In terms of epidemiology, it's more frequent in African descendants, then Asians, then Caucasians. Hispanics is almost like Asians. Not only more frequent, but also more severe disease too. And unfortunately, those patients that have more severe disease in those minorities, Africans and Hispanics, there's also the question of access to treatment, but not only to treatment once they're diagnosed, but also to start the clinical workup to be diagnosed. So there's a delay between what we can call the first manifestations until there is confirmation of the diagnostic. So it can vary, can go up to 5, 6 years when they have clinical manifestations, but they don't know what is causing it. And they can take medication that can help improve symptoms, joint pain, skin rash, but not treat the underlying mechanism of the disease. So this was a survey that was conducted in 6 different countries: US, China, Japan, Germany, Spain, France, and Canada. Involved almost 650 healthcare providers. So people that have some experience when treating lupus, could be a rheumatologist or a nephrologist. And we wanted to learn more about how COVID pandemic impacted in, like we were talking before, the diagnostic workup and the treatment and the access. And we found out with these results that the COVID had an impact on and exacerbated already things that we already knew, like the delay I was talking to you about, the access to medication, to information, to lab tests. So it made something that was not ideal even worse now with the COVID pandemic. Worldwide, we know there's this gap that is unacceptably long between first manifestations and when disease is finally diagnosed and started to treat. We know that most of the patients, when they're first diagnosed, they want to improve clinical symptoms and they're anxious to feel better. But the physicians learning with time is that we need to address this short-term manifestations that the patients want to see improvement quick, but we also have to think of the long term, their whole lifespan. So the focus today is to balance these two objectives, the short and the long term. So we want to reduce disease activity, prevent new flares, because characteristically most of the patients have relapses and remission phases. We want to prevent these relapses, but not at such a high cost that, like before, like 10 years ago, about 50% of the patients over 5 years of diagnostic have some damage. So that's too much, unacceptable. And we know that the damage decreases their quality of life. Many people that stop working, going to school, families, social life. So it's all impacted. The whole family is actually impacted by that. And also the cost, the healthcare resource utilization of a patient with damage is higher than a patient without damage. So not only a patient that can live with lupus without damage would be more productive, have a better quality of life, but also will have a lower cost, medical cost, lower burden for the whole society. We found out also at the survey that 65% of the interviewees wait a year so they start talking about the damage. And we think this is kind of scary because it would, when it happens, patient may say, I didn't know this was going to happen to me. I wasn't informed. So we think that we need to be transparent with the patients. We need to have a treatment plan, we healthcare providers, and also hear from the patients what their plans for their lives are. So we can align, like, I'm planning to get pregnant next year. I'm planning to go study at a university far from my family, go to college. So all of this has to be factoring into the treatment plan so the physicians and healthcare providers can help the patient live their dreams and their life closer to normal as possible.